Certain hot topics in audiology, of course, COVID-19, the aging population, Medicare, what are they covering these days? What about other insurance coverage for testing and hearing aids and other treatment? And then over-the-counter hearing aids and technology. Okay, so of course we all know about wearing masks and the challenges communicating with someone wearing a mask, right? So when someone's wearing a mask and talking to us, we don't see their faces. It's impossible to read their lips. During some appointments, we have to go to wearing a face shield or even a clear mask, like you can see here in the slide. And patients, many of our patients do rely on hearing as well as lip reading to communicate. Okay, there was a study that was published back in 2017, BC, before COVID, and this study looked at where people make eye contact based on their hearing. And the findings of the study were pretty intuitive. People who hear well tend to make better eye contact with their conversation partner, whereas people who don't hear as well tend to make contact with their eyes looking at the person's mouth to get the visuals. Okay, so it's a pretty intuitive study, but we wanted to include it here. It actually came out before COVID. So we found a solution to increase compatibility with masks and hearing aids. Okay, so certain types of hearing aids do not combine themselves to wear well with masks because they're competing for space over the ear. And you can see that they have these mask straps. We probably have given out over 500 of them at least during our appointments. We give them out to patients so that they can wear the mask off the ears. And sometimes I think it's the best part of the whole appointment. They say we save their ears and they feel a relief not having the mask pulling on the ears. Speech droplets, so there was a study that came out back in May of 2020 that looked at the effect of, or the combination of hearing loss and the transmission of speech droplets. And the fact that people who don't hear well sometimes speak more loudly can project speech droplets at a greater distance, and then those speech droplets will hang in the air for a longer time than if someone is speaking at a more average tone or an average volume. Also, when we speak to someone who doesn't hear well, it can lead to us speaking more loudly and us ourselves projecting the droplets more. This would be, of course, without wearing a mask. So the idea is that hearing loss can be related to increased transmission of airborne viruses like COVID because of the projection and proliferation of speech droplets. Okay. There is also seemingly a connection between tinnitus and COVID. Tinnitus, of course, is a sound perceived in the ear that is not actually being produced in the environment. Okay, it's something that people perceive inside. Most people perceive a ringing in the ear, but others hear a buzzing, whooshing, and/or a musical sound. The International Journal of Audiology estimates that about 7.5% of people infected with COVID experienced hearing loss, and about 15% of them suffered with tinnitus. About 7% reported rotary vertigo. Okay, and the British Tinnitus Association reported a 16% increase in phone calls to their tinnitus helpline and a 256% rise in helpline video chats from May into December of 2020. More research is needed, of course, to further examine the relationship. Still, it's interesting to consider. Okay, so reflection, what is the COVID-19 and hearing loss? What's the connection? Every healthcare talk should include some aspect of the population, the aging population. Baby boomers, of course, are all the rage these days. They have a longer predicted lifespan, and they view themselves as 10 to 15 years younger than they actually are. By 2035, the U.S. will have more people over the age of 65 than under the age of 18. Okay, so we've heard this phrase, the graying of America. We've been hearing about this for quite a while. The 65 and up population grew about 3% from 2018 to 2019. Folks in this age group, they want to age in place, feel young and healthy, and feel with it. So aging in place means that they want to stay in their homes. They don't want to have to go to a nursing facility or retirement home or assisted living. They want improved health span, meaning that they want to take charge of their health. They tend to be more proactive, and increasing health span, not just increasing lifespan. So health span, of course, refers to your quality of health, hopefully in your long life to come. Okay, so shifting gears a little bit, looking at Medicare, because most of the folks in this age group will have Medicare as their primary health coverage. Medicare does not cover routine hearing testing presently, standalone Medicare. Some of the third-party administrators of Medicare might, but still to this day, Medicare requires a physician referral for someone to come in for a hearing test. And it has to be complaint-driven. So that means either the primary physician is concerned about the patient's hearing, or the person themselves is complaining of hearing or some other ear complaint that is prompting the referral to audiology. Okay, so the question should be asked, is this ageism? Because for babies, newborn hearing screening is the law of the land, and it's been the law of the land in most states for over 20 years. Okay, so every baby that is born in a hospital has to have their ears checked, their hearing screened before they're discharged. So why are we putting such a focus on good hearing for babies, but maybe not making the same investment in hearing for our folks in the retirement age or post-retirement age? Okay, so it could be seen as a form of ageism. There are two audiograms here on the page. The one on the left shows normal hearing. The circles represent the right ear. The X's represent the left ear. Okay, and any mark that is seen above the imaginary line of 25, between 20 and 30, is considered normal hearing. To the right, we see a normal hearing in the low frequencies sloping to a moderate high frequency hearing loss. And this is a very typical audiogram that we might see clinically in someone whose retirement age may be late 60s, early 70s. Okay, it's very common. So some providers, even some patients themselves, will say, well, my hearing is normal for my age. I'm 75. I'm expected to have some hearing loss. I'll leave it alone. And I think there are even some providers out there who may have the same attitude. But hopefully through sessions like this, we can start to change that. There is no such thing as normal hearing for someone's age. Either someone has normal hearing or they don't. If a little baby had the hearing loss like you see on the right side there, alarm bells would be going off. We would be referring this child for all sorts of interventions, and it would be of the utmost importance that the child is not missed. Okay, so keep that in mind. There's no such thing as normal hearing for your age. Either your hearing is normal or it isn't. Just because something is common doesn't mean we should ignore it. High blood pressure can be very common for many people as they get older. It doesn't mean it gets ignored. Cataracts also are common for many people post-retirement age, but it doesn't mean that we should ignore them. Quite often people are very proactive at managing that. So we should really look at hearing in the same light. Okay, hearing aids and cost sharing. So most of the insurances that we work with and that are out there have at least some coverage for hearing aids, or they will cover part of it. And the term that we hear about a lot these days is cost sharing. Medicare as a standalone does not have a hearing aid benefit. Nationwide, the average for someone that is getting hearing aids and treatment at the retail level is typically between $4,000 and $5,000 for a pair of hearing aids. And that will typically also include all of the appointments necessary for the management of those hearing aids and that patient for typically about 4 years. So on the average, it's about $20 a week to manage a chronic health crisis and also to have the services of a full-service office and a qualified audiologist at your disposal. Over-the-counter hearing aids and personal sound amplifying products. Okay, these are primarily purchased online. They've been available for a long time. President Biden recently issued an executive order that stated within the next 120 days from July that HHS needs to issue proposed rules to allow hearing aids to be sold over the counter. And today, about 6 in 10 personal amplifying patients using these devices are using them on a daily basis. Hearing aids overall, the data is good. Reported that satisfaction is rising. 83% of hearing aid users surveyed reported that they're satisfied with their hearing aids. 9 out of 10 hearing aid users are more likely to recommend hearing aids and their provider to a peer. Okay, so quite often when people get involved with hearing aids, they realize that having a qualified professional to guide them through the process is very important. 72% of non-users of hearing aids said they would consider purchasing online, and 38% stated that they would want the latest technology plus professional service. Okay, so you're going to have a group of patients that will try it maybe by themselves first, getting something online, and then quite often they will seek out professional help. It's like if someone is getting there's beginnings of carpal tunnel syndrome, they feel something happening in their wrist. They may start with painkillers and then a brace that they'll pick up at the pharmacy to give themselves a little support. Ultimately, as that condition progresses, they're going to need medical attention. Okay, so over-the-counter hearing aids, over-the-counter solutions. One of the questions that we had is, will insurance cover over-the-counter? Because we have quite a few patients that we deal with that get hearing aids at no cost to them. So could these insurance companies a year or two down the road look at the fact now that more hearing aids are available over the counter and say to the patient, well, they can just get it themselves, why should we keep covering it? And then the burden is really on the patient. So instead of something that's helping the patient, it could actually hurt them. Who will test the patient's hearing when they get an over-the-counter device? Who will monitor the progress and success of the fitting? One of the things that most patients appreciate is a complete hearing healthcare model where all of the appointments and services are included as part of the investment in the treatment plan. Many of today's hearing aids can also be looked at as lifestyle enhancement devices. Most of them are compatible with smartphones for direct streaming, and then the smartphones also have an app that allows the user to control the volume and different program settings in the hearing aids. Some hearing aids are moving almost into the category of general wellness products. Some have the ability to send an alert to the person's companion if the technology in the hearing aid detects that the person may have fallen. There are optical sensors in some hearing aids that measure heart rate, steps, and even social engagement. Okay, so there's one lab out there that the computer in the hearing aid monitors the amount of time that the person is spending listening to a human voice, and it gives the patient a social engagement score at the end of the day. Okay, so that circles back to this concept of social interaction being important to reduce loneliness and then also to increase this level of cognitive stimulation and social interaction. There's also some research going into looking at the quality of the human voice as it's related to other health conditions. Okay, so if someone is slurring their words or elongating their sounds, it could be a sign that they're having a stroke. Okay, it could also be a sign maybe that their mental health is changing. They could be depressed or have a traumatic brain injury. So also people who would be in a manic episode could be potentially speaking at a very quick rate. Some myths and misconceptions about hearing aid technology. A hearing aid will restore my hearing just like glasses correct my vision, and I would say no to that. I wear glasses. Unless I break my glasses, I'm probably not going to go back to the optician for a year. We let patients know that it's important that we see them for at least 2 to 3 visits during the 6-week adjustment period. That's automatic with any new fitting. And then after that, we recommend about 3 to 4 visits per year. One of those would be an annual hearing test. And of course, we could adjust the prescription in the hearing aid according to any changes in their hearing profile. And then the other 2 would be for tuning and adjustments. Okay. A misconception could be that my hearing is normal for my age. As we said before, there's no such thing as normal level of hearing loss for your age. Either you have normal hearing or you don't. I can get by with just one hearing aid even though I have hearing loss in both ears. So typically that would just give you a different problem. It would throw you off balance. It would really take away your ability to localize sound, because the way we localize is with 2 ears working equally. And then also it can help the non-aided ear to decrease more quickly through auditory deprivation. A hearing aid can make my hearing worse. Well, if it's not professionally managed, maybe it could. If it's not set for you, if you're using a hearing aid that was passed on to you maybe from someone that doesn't use it anymore, doesn't need it anymore, if it's not set properly, it's professionally managed, it could make your hearing worse. So reflection, ageism, is hearing loss normal at any age? So some different patient experiences. These are some real quotes that patients have said to me during appointments. They shun me. This was a lady whose hearing was at the point that her fellow churchgoers avoid having a conversation with her because it's very, very challenging for her to communicate with them because she just needs constant repetition. You're the only person I spoke to today. So this was from one of my front office told me that they called a patient to confirm the appointment, and the gentleman kept her on the phone for about 10 minutes just catching up and chatting, and then he apologized to her. And he said, "Oh, I'm so sorry that I kept you for so long. It's just that you're the only person that I spoke to today." Okay, so I think we have to keep in mind that some people really are feeling like they're out there in their own little island and they really need that connection. I have to force myself to hear, so this just puts some light on the fact that some people really strain and struggle to hear and they really overwork their brain just to try to understand what's being said. When they say it's not important, it means I'm not important. So this is a patient that told me that sometimes she'll need a family member or someone else to repeat something like 3 times to her. And then the person, if she's still not getting it, the person will say, "Oh, forget it, it's not important." And it makes her feel terrible. It makes her feel like she's not important. Not important enough for the person to find another way to restate it to her or to repeat it the 4th time. I feel like a real little girl. Okay, this was a pediatric patient that we fit with hearing aids, and then she felt much more included after that process. My family's fed up with me. Sometimes a phone call is better than any medicine. And then an example of mishearing or misunderstanding could be Michelangelo painted the 16th chapel instead of the Sistine Chapel. So this is a true story that a colleague of mine, she's a physician, she told this story at a conference and she gave permission for us to relay it. This is about her mom who had a medication error. Her mom combined Celebrex and ibuprofen. These are both non-steroidal anti-inflammatory drugs, which resulted in a GI bleed because she took both at the same time. She was supposed to discontinue the ibuprofen, but she wanted to be a good patient and adhere to the advice, so she took both. Unfortunately, the result was that she lost 25% of her blood volume. She became anemic, and it resulted in multiple procedures in order for her to regain her health. Okay. Subsequently, her daughter took her to an audiologist to get her hearing taken care of. After the hearing aid fitting, she was able to have a successful restaurant visit with her mom. They went to a diner and had lunch, and they were actually able to communicate with less effort. Family members got back into a normal way of interacting with the patient, so it made it easier for the family as well. The patient's demeanor changed. She was smiling, much more energetic. She stopped talking about being at the end of her meaningful life and stopped talking about taking her life. So the perspective of her daughter was that it really saved her life. It was a remarkable visit resulting in a trust relationship between the patient and her provider. And it just means that we all have to look beyond maybe the test results or the patient that's in front of us, maybe even look at the support structure. Sometimes we're not only treating the patient, we're treating the family. And Cousin Bob. Cousin Bob is a real person. He doesn't look like that, but he does for now for this talk. So Cousin Bob is my mother's cousin. He's about 80 years old. And growing up, Cousin Bob would always bring a book to all of our family events. And he would say hello when he got there, and he would find a corner and sit in a corner and read his book. And then it was time to eat, so he would come to the table and eat, and then he was gone. He would be back in the corner reading his book. And when I was a kid growing up, I really didn't care because he was old and I wasn't, and I just ignored him and left him to himself. But as we got older, I realized that Cousin Bob doesn't hear well, and his way of not dealing with it really is to just separate himself from the group. So he physically was present, but he wasn't really including himself. Ultimately, he has a cochlear implant now. He's a veteran. He goes to the VA in New Jersey. He's doing well, gets very good service there. He has a hearing aid in one side and a cochlear implant on the other side. And he really is doing much, much better. He's much more interactive. And I think many of us could see in our own families or people in our own lives that may be present when we have family gatherings, but maybe they are sitting off to the side, or they're sitting at the table, but they're not really participating. Okay, could it be that their hearing is changing and it's too challenging or too frustrating for them to participate? So I think it's something really to reflect on. And we talked about not only the fact that we are helping patients, but we're really helping their families and the community. Because when someone has a hearing problem, it's not just a problem that they have, it's really a communication problem. Okay, so it really leads to a problem of the greater group. So definitely wanted to thank Dr. Reinhardt and Dr. Donovan for the opportunity to present this, and look forward to the next one. Thank you.